Welcome to the first Journal Club of calendar 2023. Before we begin, a land acknowledgement. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit and Métis people, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations and more concrete acts of reconciliation. Our program and this journal club have previously made financial donations to women's Indigenous groups in the country. As another concrete act, for those of you who read bedtime stories to young children, Sweetest Kulu by Selena Kaluk has captured our kids' attention and served as an introduction to teach our children about the history of this land. I will post the link in a chat in a moment. We are starting this year off very well with two presentations from our STAR PGY5 co-chief residents. Our first speaker, Dr. Guillaume Lim Fat, a prior CGS Régent Hébert Award winner, and with a special interest in quality improvement, to present on IADL associations with Ministry of Transport notification from an academic memory clinic in Ottawa. And we are so fortunate this morning to have Dr. Frank Nofel with the Briere Institute joining us as the lead author on this paper. Welcome. And over to you, Guillaume.
Thanks for the kind introduction. I'll get right into it. So hi, everyone. Today, I'll be presenting, as mentioned, on the article titled Decline in Other IDLs as Indicators of Driving Risk in Older Adults at an Academic Memory Clinic. I have no conflicts of interest to disclose. So this paper was published earlier this very January in MDPI Geriatrics. It was led by a group out of the Briere Institute in Ottawa, so our neighbors down the 401, consisting of Drs. Frank Nofel, Shireen Hossein, and Amy Su. And as Dr. Gandel mentioned, we're very privileged this morning to have Drs. Nofel and Su joining us for the Journal Club. Welcome, and we'll have some time dedicated at the tail end of this conversation to add any further commentary or insights and to participate in the discussion. So to set the stage for this, by 2030, 1 in every 4 drivers in Canada will be age over 65. We know this is the fastest growing population segment in terms of drivers, and that driving performance is affected by cognitive decline. There's an unfortunate number of studies that show clear associations between dementia and increased crashes in drivers. We also know that driving cessation is devastating for older adults. So it's associated with a number of adverse outcomes, including loss of independence, decreased social engagement, increased depressive symptoms, risk of mortality, and nursing home placement. For this study, the authors focused on particularly the fact that patients and their caregivers are often not sufficiently prepared for the possibility of driving retirement. And this is something we commonly face in our geriatric medicine clinics. We also acknowledge that primary care physicians often lack time or access for assessment of driving risk with specific tools and/or a really comprehensive cognitive assessment. And so self-assessment tools of driving risk are being explored, but currently are relatively lacking. So the authors of the study set out to compare the clinical profiles of older adults who were referred to the driving authority, and by that we mean reported to the Ministry of Transportation, or MTO, comparing those who were not referred so as to identify indicators of high driving risk. The goal of this was to identify elements that older adults and their caregivers could use to help prepare for medical appointments where driving might be discussed. So this was a retrospective observational study with secondary use of clinical data on older drivers assessed at an academic memory clinic in Ottawa. And that memory clinic is the Briere Memory Clinic, which is exclusively dedicated to cognitive assessments. It was a comparison of clinical characteristics of two different cohorts. So the first were drivers who were referred to the driving authority or the MTO, and drivers who were not referred to the driving authority, with 50 drivers, excuse me, with 50 drivers in each group. The data collection started in November 2021 and was done in reverse chronological order, identifying 50 referred and 50 non-referred drivers. So this was a random convenience sample. The risk factors examined were functional impairment, modified mini-mental state examination score, or a 3MS score, TrailsB performance, and clock drawing performance. The inclusion criteria was relatively broad, as they needed a more or less complete data set consisting of a 3MS, a clock draw, and a TrailsB within 6 months of the appointment. And the only exclusion criteria explicitly mentioned was an active psychiatric condition, though they specified that mild depression could be included, so patients could be on an antidepressant and still be included. The functional decline was reported as assessed in the functional history of the assessments, and the IADL specifically reported for this study were appointments, medications, bills, computer use, and television use. I won't go into all the statistical tests that were used, but one that I'll bring your attention to is that they use logistic regression models fitted to estimate odds ratios for variables predicting the risk of being referred to the MTO. I'll keep this on the slide though for if anyone wants to refer to it later on. So this is the baseline characteristics by referral status, referred drivers and non-referred drivers. The one thing to note here with the positive p-value at less than 0.05 is that referred drivers were generally older than non-referred drivers at 78.2 years old compared to 72.9 years old. The other p-values didn't quite reach significance, but there was some noticeable things like a greater proportion of males in the referred drivers, as well as a smaller proportion of those with college or university education. In terms of the results, referred drivers, so those who were reported to the MTO, on average had higher number of IDLs with impairments at 1.96 compared to 0.72 in the non-referred group. They also had, predictably, worse performance on TrailsB at 70% compared to 6% needing over 3 minutes to complete TrailsB. Worse performance on clock drawing tests at 47% compared to 8% of patients having significant errors in their clock drawing, and lower 3MS scores at a total score of 76.46 on average compared to 91.2, where the normal range for 3MS is between 80 and 100. This is the same data in table format. The only additional things I'll bring your attention to here is that they also reported the number of charts where the data was missing. And you can see this is relatively low across the board. And they also reported the standard deviations, which were relatively tight. Because we're very geriatric keen here, I'd also bring your attention to the supplementary materials where they went over 3MS subscores. So it's interesting to look at where these patients had significant differences in their scores when you compare those who were referred to those who were not referred. You can see it was on immediate recall, temporal orientation, fluency, abstraction, writing, copying pentagons, and delayed recall. Now, looking at these, I don't find any specific pattern to the domains affected, but it's really across the board, as we might expect, visuospatial, of course, but also frontal dysexecutive, some language domains, as well as some amnestic component. In terms of the odds ratios that were able to be calculated, so the odds are being referred to the driving authority, we see that with every increase in count of IADLs with decline, there was an adjusted odds ratio of 2.01 of being referred to the driving authority. And they also reported odds ratios for the specific IADL domains being affected, reported down here, and all of them did reach statistical significance aside from computer use. Now, the highest odds ratio out of these was use of the television at 12.6, which is a quite high odds ratio, but also acknowledge that the confidence intervals, the 95% confidence intervals for these are quite wide. So for this one, it's 1.5 to 100.5.1, which suggests some heterogeneity to the data. Now, finally, this is a chart summarizing the typology, the exact permutations of IADL decline stratified by referral status. So for example, if we were to look at patients with 3 IADLs impacted, what were the exact 3 impacted, separated into those who were referred and not referred. I annotated these with totals just to summarize things a little bit for the sake of this presentation. So going through it, we see that out of all drivers who had 0 IADLs in decline, 31% were referred. So there were 14 drivers who, despite the fact that they reported no IADLs showing decline, required reporting to the MTO. And as we might expect, as the number of IADL domains affected goes up, so does the percentage of referred drivers. So at 1 IADL impacted, 36% were referred, 2 IADLs impacted, 52% referred, 3 IADLs impacted, 80% referred, and at 4 IADLs impacted, 100% referred. Some interesting things here. So for example, the CMA driver's guide would suggest as part of their guidelines that anyone with 2 IADLs affected or more should be considered for referral to the MTO, but the guidelines are just that, a guide to help guide our clinical decisions. And myself included, with anyone doing cognitive assessments and really comprehensive assessments, we weigh in much more than just the number of IADLs impacted. And so we see, even though some patients had 2 IADLs impacted, 52% were referred, so 10 of those patients were not referred. And there was even a number of patients with 3 IADLs impacted who were not referred. So 3 patients had 3 IADLs impacted as a result of their cognitive impairment, but were not referred to the MTO. And they do go into further detail with those 3 specific cases, citing that each of those 3 were aged less than 75 and had normal scores on the 3MS, a Trails B less than 3 minutes, and a normal clock draw free of any significant errors. That reflects our clinical practice too, where a lot of the time we may have patients who report significant functional impairment that in contrast isn't quite reflected on the formal cognitive testing and by the end of our assessment. So concluding from those results, that with every additional IADL impairment, there was additional 2-fold increase in relative risk of being referred to the driving authority or reported to the MTO. And so that IADL impairments are a promising indicator for primary care physicians and really other clinicians assessing driving risk. There's also a potential role for IADL impairment for self-assessments that older adults and their caregivers could use to facilitate the discussion of driving retirement. Going quickly into the critical appraisal, I wanted first just to share a tool, particularly for the trainees, to help evaluate for risk of bias in non-randomized studies. So this is the Robbins E tool, specifically for non-randomized studies of exposure. It doesn't 100% fit into the design of this study, so I won't go step by step into these domains. But if we consider this to be a quasi case control study where the outcome of interest is either being referred or not referred, and the exposure that we're looking at is whether they had IADL decline or not, it more or less works. And so this is what I kept in mind when going through the strengths and limitations. The strengths being that this was a simple and pragmatic design to compare ostensibly high and low risk drivers. I love the fact that they used measures that were commonly used in the clinical setting. So I know exactly what they mean when they say the Trails B takes greater than 3 minutes, as opposed to more research-centric measures like an ADAS-Cog, for example. There's also minimal missing data, and they were quite transparent about where that was. And the patient population is very similar to that seen in our own clinic. So that last strength may be specific to us here in Toronto or in Ontario and Canada as a whole. But I do think that their patient population is relatively representative of ours, though they do acknowledge that at the Bruyère Institute, there tends to be a smaller proportion of visible minorities. The limitations of the study mainly is that it's an observational studies design. And so there's lots of possible confounding biases, including the difference in age that was reflected in the different groups. So we don't know whether age also affects the decision for a clinician to refer or not refer. We also note the small sample sizes, relatively small, and that the functional impairment reporting really relies on the patient and their caregivers reporting of function at home. So these aren't necessarily objective. There's also the fact that referral to the driving authority as a whole, even though it's a very important outcome, is really just a surrogate of driving risk. So we don't know the exact driving performance of these patients. It's not an on-road driving test. In terms of implications for practice, really this facilitates discussion, which we know is critical for early planning and promoting shared decision-making. Now, primary care providers have an additional validated marker for risk stratification that is easier and quicker to use than something like a TRAILS-B or clock draw. And future prediction models may come that include IADL self-assessment for older adults and their caregivers to better prepare for conversations on driving retirement. I know these are the hardest conversations for me to have, and so anything that helps prepare those patients and their caregivers before they come to the specialist office is very welcomed. I'd like to share a number of resources, particularly the Brain Exchange Driving and Dementia Resource Center has links to many of these, but drawing particular attention to the Driving and Dementia Toolkit that Dr. Nagley and Rappaport developed. It's fantastic. And they'll be giving a grand rounds presentation on the use of this on February 2nd. There's also, of course, the CMA Driver's Guide 9th edition with an update in 2019 on Section 8, which has to do on driving and dementia. I do believe there's also a 10th edition coming out later this year. And we'll be having an academic half day for trainees on March 20th, led by Dr. Nagley. If any trainees would like to join, please let me know. I'm happy to send you the link. So now I'd like to turn to the authors if they have any additional comments, commentary, or insights. Thanks for your attention.
Thank you, Guillaume, very much as always. Absolutely phenomenal. Tend to forget that you're PGY5. And particularly in the presence of the lead authors of the paper. So fabulous, congratulations. And please open to comments and questions. Please feel free to raise your hand. Go ahead, Gary. I'm looking at the hands from the reactions. Go ahead, Gary.
Thank you, Guillaume. Excellent presentation, as always, and I appreciate the shout out. I guess the one question I'd like to ask about is the issue of inclusion bias, in the sense that the various elements that were looked for as predictors were not things that the assessors were blinded to. So they were taking this information into account to make their decision as to whether to refer them. So I wonder if you have any comments about the particular impact that had on finding these things to be predictors.
Cool, I'm happy to have the authors here to speak directly on their own behalf. But at the same time, I like to see from my perspective, that's an inherent risk with most observational or retrospective studies. I didn't see the justification in detail for the specific markers being chosen and perhaps why some were omitted, but I'm very happy to have them here to provide further insight.
Go ahead, Dr. Nofel, please.
Right. Thanks. I want to say, Guillaume, you did an amazing job at presenting our paper. You made it sound a lot better than it was. But anyways, I wanted to first go and give you a little bit of background how this sort of came about, because it's really an organic kind of thing. And of course, the first thing I want to do is acknowledge that we hadn't seen the cool website that Gary and Dr. Rappaport had put together. So that was missing in our background, and we, anyways, so I want to acknowledge that. Having said that, this started, as I said, about a year and a half ago, and it started as a fourth year science student project, where all we wanted to really do was look at, what kind of data were we collecting from patients that was sort of reproducible, and what simple comparison of those that were referred to those that weren't referred, and that became a fourth year project. And so subsequently we said, well, there are things that need a little bit more in-depth analysis, and that's when I and Dr. Xu joined us, and she's the statistical brains behind this paper. And so then we started to look at things in more detail, and we actually went through a number of iterations of this paper with thanks to the reviewers who helped us focus and improve it over time. So yeah, so that's just sort of the background of how the paper came to be. With respect to including variables or not including variables, it ended up having to be somewhat subjective, right? So we collect information about, excuse me, instrumental activities of daily living in our histories, but it's not consistent. It's there's a self-assessment part, which is part of the application that the patient does while they're waiting to come to the clinic. That's a personal sort of highlight of the ADLs where they feel, or IADLs that they feel that they've had changes. Then the physicians will repeat some of those, but the documentation is not fantastic amongst the different clinicians at the clinic. So we had to sort of select those that were reporting it more continuously and consistently, and so there's definitely some bias there. Was there another part, Gary, that you wanted to ask about, specifically about things we might have included or excluded, or how that came to be? I mean, obviously, if the data was incomplete, we didn't include the patient because we sort of had to narrow it down to things that were consistent enough that we thought we could use the patients, and that, if that makes sense.
Dr. Nofel, it's Jennifer Watt here. Actually, I had a question related directly to that, so it's probably, I don't want to jump in, but in a way I do. Do you know, like for the IADLs, how many people weren't doing these IADLs like for their whole life? You know what I mean? Like some people just never did these things. And so I think that's really important to like understand, you know, whether this would represent a change related to cognitive decline, or if that's just like the way their household did things.
Excellent.
And
yeah.
and then the other related to that is like, you know, sometimes, and I don't know like what is the standard practice in your clinic, but like sometimes say somebody wasn't driving for like 25 years and they said like, I don't own a car, I'm never going to drive. Like sometimes, you know, clinicians they'll say, okay, I'm not going to necessarily refer. There's some people who always do, like I do anyway, but I know there's some people who don't. And so I guess that would be my other question, is just like, what is the standard practice in your clinic in terms of like when you would refer people versus when you'd say, okay, this person's really impaired, but like, I'm not worried that they're going to be driving anyway. And so like, I'm okay with that.
Both excellent questions. So first one, we did try to have it identified that there was a decline in that instrumental activity of daily living. So if you've never cooked a meal and now you're not cooking a meal, that was not included. So it was some kind of documentation that you used to cook for the family, now you have difficulty boiling potatoes or something like that. Now meals were excluded because for exactly that, we found too much gender mess and things like that, so we ended up not including meals, for instance. But so we tried to get ones that were consistent and where for sure there had to be a note. They used to manage the TV remote well. Now they're having difficulties changing channels, or they want to change the channels, but then the volume goes up or things like that. So it's fuzzy, but we were careful to say an idea had to be a decline. So it had to be documented that there was a decline. That's the first part. The second part of your question was around people that didn't get referred to because they didn't drive. And you're right, that is a problem in this case, because we don't all refer patients that aren't driving to the MTO. And you're right, that the rules are we should, but it's hard enough to refer the drivers. We figure, you know, a non-driver getting a letter. Anyway, so just to say that is a point. So we did, there might have been people, there would have been numbers of people that were skipped because they weren't drivers. So good question and good point.
Thank you.
Thank you very much. Out of the interest of time, Dr. Zhu, I will give the last question or comment over to you. Michael, thank you for raising your hand. Please submit in the chat box nonetheless. we do have a second presentation this hour. So thank you again to the authors for joining. Last question or comment to Dr. Su.
Yeah, I'll keep it short, and happy to kind of stick around for a few more minutes to answer your questions. I think the main thing I wanted to point out is that with the data that we have, certainly there are limitations. It's actually part of a larger program where we're trying to build prediction models. So my expertise is in building prediction models in a clinical setting. And one part of that, so we follow the PROGRESS framework, which is the Prognostic Research Strategies framework. And one part of that is just to understand correlations and associations between what we're observing in clinical settings and some of the outcomes. And of course, the referral to MTO is not necessarily an indication that they will get into a motor vehicle accident, right? So thinking about what this means, I think it's just an exploratory study to look at some of these factors. And that's just one stage in the prediction modeling. Happy to answer any other questions. And I see that there's a comment there, but definitely I want to respect the time for the second presentation.
So thank you again to Guillaume for a wonderful presentation, and both Drs. Nofel and Zhu for joining. Such a rich discussion, and the attendance today certainly reflects that. So to the next presenter, our other co-chief resident, Dr. Amanda Chen, with an interest in qualitative analysis and currently investigating the experience of physicians in long-term care during the COVID-19 pandemic, but is here to present on haloperidol and delirium in the ICU. Amanda, over to you. Please feel free to share your slides and start.
Okay, awesome. Thank you so much for the kind introduction. Hi, everybody. My name is Amanda. I'm a PGY5 geriatric medicine resident. And today I'll be presenting on the article Haloperidol for the Treatment of Delirium in ICU Patients that was first published in October of 2022. I have no conflicts of interest to disclose. For the objectives today, I will be reviewing the definition and pathophysiology of delirium. I will also provide an overview of more recent literature that evaluated antipsychotics for the treatment of delirium. I will then proceed to review and critically appraise the 8ICU trial. A quick definition about delirium. So it was a term that was first derived from the Latin word delirare, which meant to go out of the furrow. It is a syndrome that's characterized by the acute change in attention, awareness, and cognition, and is caused by a medical condition that cannot be better explained by a pre-existing neurocognitive disorder. There are several different hypotheses of delirium pathophysiology, which we'll briefly outline here. Initially, there are precipitants that would lead or trigger the development of delirium, and this includes quite a long, extensive list of factors. But things like electrolyte abnormality, fluid imbalance, neurological disorders, nutritional deficiencies, infections, cognitive function, toxins, and many others. Some of the key processes that's identified outline the changes in brain connectivity, neuroinflammatory and glial cell alterations, and vascular changes. So brain network connectivity is impaired over time by aging and neurodegeneration. The cholinergic and noradrenergic neuronal populations degenerate over time as well with increasing age and dementia. The microglia and astrocytes are thought to be primed by existing neurodegeneration to produce exaggerated pro-inflammatory responses to secondary inflammatory stimuli. And as well, aging and neurodegeneration triggers alterations in brain vasculature, leading to impaired perfusion and vascular reactivity, disruption of the transport of important plasma proteins into the brain, as well as leakiness of the blood-brain barrier, which potentially makes the brain more vulnerable to disruptions of energy, oxygen supply, and the effects of circulating inflammatory molecules. The neuroinflammatory hypothesis proposes that peripheral inflammatory processes, such as infections or surgeries, can induce activation of brain parenchymal cells, which expresses inflammatory cytokines and many other inflammatory mediators in the CNS system, such as CRP, IL-6, TNF-alpha, etc., that leads to neuronal and synaptic dysfunction. And the aging process is the accumulation of oxidative damage to cells. That's known as the free radical theory of aging. And in aging and delirious brains, there is a decline in the normal antioxidant defensive mechanisms, which increases the vulnerability of the brain to the effects of the oxidative damage. Lastly, aging is associated with age-related cerebral changes in stress-regulating hormones and signaling, and aging can also reduce the tolerance of glucocorticoid stress hormones. Ultimately, these factors and potential hypotheses of pathophysiology lead to acute brain failure. So just going over some of our current studies of antipsychotics use in delirium management. So in this 2018 RCT trial, the group aimed to understand the effects of IV Haldol, ziprasidone, or placebo on the primary endpoint of number of days alive without delirium or coma during the 14-day intervention period in the ICU. Their secondary endpoints are 30-day and 90-day survival, time to freedom from mechanical ventilation, and time to hospital, ICU and hospital discharge. Important thing to note about this study is that the majority of the patients were found to have hypoactive delirium, consisting of 89% of the participants. Overall, there's no significant effect that was found with either the use of Haldol, ziprasidone, or placebo on their primary endpoint. Next, we have this Cochrane review from 2019, where the objective aimed to assess the effects of pharmacological interventions for treatment of delirium on duration of delirium in critically ill adults with confirmed delirium, and examining different drugs that included antipsychotics, dexmedetomidine, statins, opioids, serotonin antagonists, and cholinesterase inhibitors. Overall, there is no evidence that was found of a difference between placebo and any of the drugs in terms of delirium-free and coma-free days, days with coma, physical restraint use, length of stay, and long-term cognitive outcomes or mortality. Subsequently, there is another systemic review from 2019 that aimed to review the effects of Haldol for the treatment of delirium in critically ill patients. It included a total of 8 RCTs. At the end of the study, there was no significant effect found from delirium versus control on all-cause mortality or delirium severity. This is another systemic review in 2019 of RCTs that compared Haldol versus placebo for treatment and or prophylaxis of ICU-related delirium. It included a total of 6 RCTs, and there was, again, no significant difference between Haldol and placebo-treated patients in short-term all-cause mortality, incidence of delirium ICU stay, or delirium coma-free days. This kind of leads us back now to the introduction of our current trial, Haldol for the treatment of delirium in ICU patients. So this is a multi-center, blinded, parallel group, placebo-controlled clinical trial with centralized randomization to evaluate the effect of intravenous Haldol, which meant 2.5 milligrams 3 times a day, plus 2.5 milligrams as needed, to a total maximum of 20 milligrams on patients with delirium in the ICU with a primary outcome of number of days alive and out of hospital at 90 days after randomization. In terms of our PICO question, the study included 18 years or older individuals who have been admitted to the ICU for an acute condition and received a positive result for delirium according to either the CAM ICU score or the intensive care delirium screening checklist. The intervention is said is IV Haldol 2.5 milligrams 3 times a day and up to a total of 20 milligrams as needed every day. Our comparator is placebo, And the primary outcome was the number of days alive and out of the hospital within 90 days after randomization. They also looked at a number of secondary outcomes. So it included the number of days alive without delirium or coma in the ICU at 90 days. And this is defined according to the Richmond Agitation Sedation Scale, the Ramsay Sedation Scale, the Motor Activity Assessment Scale, or the Glasgow Coma Scale. The authors looked at the number of days alive without mechanical ventilation at 90 days, the number of patients with one or more serious adverse reactions to Haldol in the ICU, the total number of serious adverse reactions to Haldol, the number of patients receiving rescue medications, and rescue medications refers to when there are cases of uncontrollable delirium. They can receive rescue medication, which might include propofol, benzos, or alpha agonist at the discretion of the clinical team. The number of days with, lastly, the number of days with rescue medication per patient. In terms of the methods, so it was randomized at 16 general ICUs in Denmark, Finland, UK, and Italy. It was funded by the following: Innovation Fund Denmark, Regional Medicines Fund, the Zealand Region Research Fund, Intensive Care Symposium, Heinzgav, and Fox Foundation. Overall, the funding sources had no influence on trial design, conduct, data collection, analysis, or reporting, and the funding organizations do not have ownership of the data. Moving on to the inclusion and exclusion criteria. So inclusion criteria are for individuals aged 18 or older, admitted to the ICU through an acute non-planned admission, and is diagnosed with delirium by either CAM-ICU or ICD-SC. It does not include planned recovery after surgery or similar planned admissions. It does not include admission to semi-intensive care or intermediate intensive care units. The exclusion criteria are as follows. So anyone who has contraindications to Haldol, which can include a history of intolerance to the medication, known Parkinson's disease or other EPS symptoms, known QTc prolongation, history of tardive dyskinesia, ventricular arrhythmia, or uncorrected hypokalemia. Habitual treatment with antipsychotic medication, so individuals who have daily intake or use of prolonged release medication of any antipsychotic. Treatment with antipsychotics in the ICU prior to the inclusion, so which meant if they had been treated with antipsychotics prior to the ICU stay. So antipsychotic treatment, if it's not habitual in the general ward due to delirium prior to ICU, was accepted, but it was discontinued when the patient was first admitted to the ICU. Permanently incompetent patients, so someone who is permanently unable to make decisions about their own affairs, and they may or may not have a legal guardian. Delirium assessments that's non-applicable. So this included language barriers where delirium assessment cannot be confidently performed by the site staff, individuals who are deaf, blind, or aphasic. Comatose patients are also not applicable for delirium assessment. Participants who withdraw from an active therapy or brain death, known pregnancy, consent that was not obtainable, or patients under involuntary hospitalization or alcohol-induced delirium. Looking at the study design, so this is a simplified modified graph from the appendix, but 491 participants were included in the analysis of the primary outcome in the Haldol group, because at the end, 10 did not give consent or did not have consent provided by the SDM. 472 were included in the analysis of the primary outcome in the placebo group at the end, because 14 did not provide consent or did not have consent by the SDM. In terms of the statistical analysis, the primary outcome is days alive and out of hospital within the 90-day intervention period. Statistical analysis was completed with intention to treat analyses All analyses were adjusted for stratification variables, trial site, and delirium motor subtype. And the group used a linear regression model to estimate the adjusted mean difference between the groups. In the secondary analyses of the primary outcome, these were adjusted for additional predefined risk factors at baseline. So it includes the presence of traumatic brain injury, stroke, mental illness, neurodegenerative illness, alcohol overconsumption, substance abuse, benzo, tobacco smoking, and predicted 90-day mortality, and the use of Haldol before ICU admission. The primary outcome was then further analyzed, and the heterogeneity of treatment effect was evaluated in pre-specified subgroups defined at baseline according to trial site and delirium motor subtype. So hyperactive versus hypoactive, ICU, that's admission, that's medical versus surgical, sex, female versus male, age, less than 69 or greater than 69, and patient with one or more risk factors of delirium, as well as disease severity. In terms of the results, so this is the baseline characteristics table. Just to point out a few specific items, so the median age of the group was around 70 years old. The delirium incidence in the ICU affected more men than women, so around 60 to 65% are men. In terms of race and ethnicity, because these are Northern European ICUs, they're predominantly 90 to 95% were white. And of note, very few participants in this trial have a history of neurodegenerative disease. This is the second part of the chart. So different from the 2018 trial earlier that evaluated Haldol, ziprasidone, the participants here have a much more equal distribution of the motor subtype, which included hypo and hyperactive delirium. This is also an extension of the graph. So close to over 50% of the participant needed to receive additional rescue medications. So specifically, it's alpha-2 agonist for the majority. Some participants also withdrawn for the trial, primarily because they withdrew consent. And as a result, they were exposed to open label antipsychotic agents. And this is about 13% of participants. That's similar in both groups, which received open label antipsychotic agents. Looking at the primary outcome, at 90 days, the mean number of days alive out of the hospital was 35.8 days, with a 95% confidence interval in the Haldol group and 32.9 days in the placebo group. The graph refers to the survival curves for the Haldol and placebo group, and the data was censored at day 90. This table kind of shows the main and subgroup analyses of the number of days alive and out of the hospital within 90 days after randomization. There was no heterogeneity of treatment effect that was found for the primary outcome in the pre-specified subgroups. This table outlines the secondary outcomes, which looked at days without delirium or coma, days alive without mechanical ventilation, serious adverse effects, and the use of rescue medications, which are its secondary outcomes. Overall, I think it's quite generally relatively balanced throughout the groups. In terms of adverse effects, so the number of patients with one or more serious adverse reactions was similar amongst the two groups. No patient had more than one serious adverse reaction. The trial regimen was discontinued in 12 patients, so 2.5% in the Haldol group and 7 patients, 1.5% in the placebo group, because of QTc prolongation. Another 15 patients in the Haldol group and 24 patients in the placebo group had the assigned trial regimen discontinued by clinical staff for other reasons, but it's unclear what. I couldn't find it in the appendix. Moving on to critical appraisal. So was the assignment, my apologies. Was the assignment of patients to treatment randomized? Yes, eligible patients were randomly assigned in a 1-to-1 ratio and blinded to either placebo or Haldol. Were the groups similar at the start of the trial? Yes, I would say so overall. Aside from the allocated treatment, were they treated equally? Yes, overall they were. Were all patients who entered the trial accounted for, and were they analyzed in groups to which they were randomized? So not everyone was accounted for. So 9 in the Haldol group did not receive Haldol at the end and were excluded. 10 in the Haldol group also did not then provide consent and was excluded from the primary outcome analyses. 4 in the placebo group did not end up receiving placebo and was excluded. And 14 in the placebo group ended up not giving consent and was excluded from the primary analyses. Were measures objective, or were the patients and clinicians kept blind? Yes. What is the magnitude of the treatment effect? So overall, no significant difference in their primary outcome in the number of days alive without delirium or coma, or in mortality at 90 days was observed between the two groups. What were the adverse effects? We talked about that a few slides ago, but including anaphylactic reaction, agranulocytosis, EPS, neuroleptic malignant syndrome, tardive dyskinesia, etc. Do these results apply to our patients? I think potentially in certain specific subsets of patients. Is our patient so different from those in the study that its result cannot apply? Potentially as well. I think one of the big important things to note in this study is that the majority of the patients did not have a diagnosis of neurodegenerative disorder prior to admission to the ICU. And I think this can be very different from our patient cohort that we see clinically in everyday practice. Is the treatment feasible in our setting? I think likely yes, but potentially with changes in the Haldol dosage and route. Because all individuals received IV Haldol. What are our patients' potential benefits and harms from the therapy? In terms of benefits, it would be a management of delirium symptoms that may potentially pose a risk to the patient themselves or other individuals. And the risks is other risks are rare adverse reactions. Concluding now is that overall, no statistically significant difference between Haldol and placebo group within the number of days alive and out of the hospital at 90 days. In the discussion, they had kind of explained that there's a very small signal that mortality may have been lower with Haldol versus placebo, but no conclusions can be drawn at this time. Thank you very much.
Thank you very much, Amanda. As always, for a phenomenal presentation, clarity of speech and these slides. Karen De Silva has her hand up. Go ahead, Karen.
Thanks, Amanda, for a very intriguing presentation. I'm just curious, what are your thoughts about the primary outcome and its relationship to your practice? How did you feel about the primary outcome?
Yeah, I think that's a great point. Thank you, Dr. De Silva. I think looking at the various prior recent literature, most of the time they did evaluate days alive, either 30 days, 90 days, 14 days, or as well as the mortality risk. I think in terms of our general patients, so the majority of patients I see are, 80, 85 and above. And at the end of the day, the mortality risk, it depends. I think it depends on their medical comorbidities, but at the end of the day, potentially symptom control at the time of admission and making sure that the delirium management is safe and not at risk of harming themselves or other may be important for the patient as well as the patient family. Yeah.
I find it very interesting for a number of reasons. When I was a medical student, I spent a month in a Danish Copenhagen hospital. I can attest to the fact that their care is fantastic, wonderful. I wrote to the primary author on this. I wrote it, sent a copy to Gary. She said, by the way, her mother's a geriatrician. She said that as an outcome of the study, they certainly do all interventions other than medication, especially having family there with the person who's delirious, speaking to them, holding their hands, etc. But her practice is still using Haldol in the case because of lack of anything better, and at least showing that it's not worse than the alternate medications, in this case placebo. And I think the problem is all of us in that situation who do ICU care in general hospitals for sure, should not be afraid of using Haldol because at least the adverse effects are not substantial. And we don't have a lot of other things that work. Thank you.
Thank you, Michael, for sharing that. Any other questions or comments? Amanda, I wonder, thank you, Gary. Just before I take Gary's question or comment, I wonder if you thought the results, I know they did a subgroup analysis of hyper versus hypoactive. I wonder if it was a type 2 error, was the sample too small or the subgroup too small to detect the difference with the hyperactive group?
Sorry, the sample size may be too small to detect a difference in the hyperactive group.
That's right.
Yeah, they included about 400, 500 individuals. So that could definitely be a possibility. Compared, I was reading in terms of the 2018 trial where the majority of participants had hypoactive group. I think at the end of the day, this is a more balanced between the two, but there is definitely a potential for a smaller trial size. That could be an error.
Thanks. And similarly, Christina, thank you for your comment in the chat. Mentions, did the authors provide any justification for why they included hypoactive delirium in this study? And after you respond, we'll take Gary's question as well. Go ahead.
Thank you. Yeah, I was just about to type back to Christina. No, so I read through the paper as well as the appendix. I was not able to find a specific justification for the subtype for hypoactive delirium.
Go ahead, Gary. Thank you.
Yeah, I apologize for my ignorance. I'm trying to understand what's being treated. I mean, I, through all my many years, understood that with respect to delirium, we are treating symptoms that make it difficult to care for the patient or result in possible risk to the patient or to others. So here we have a study with IV haloperidol, includes a large number of people with hypoactive delirium. And so I need some explanation. I'm trying to understand, what are we treating? So it seems like there's a belief that antipsychotics can treat the syndrome of delirium as opposed to targeting the symptoms of delirium. And maybe I missed something over recent years that suggests that that's in fact the case. I'm just not sure what is being treated.
Yeah, thank you, Dr. Nagley. I think that's a really good point in terms of the individuals with hypoactive delirium. What are we exactly treating? I was not able to find a clear explanation in the review in the article.
Have you come across any literature that speaks to or suggests that antipsychotic medications can treat the underlying pathophysiology of delirium such that we would want to use it regardless of whether it was a hypoactive versus a hyperactive delirium?
I'm happy to accept any other comments as well, but in terms of my review, preparing for this presentation, looking at the different systemic reviews that I outlined above, I did not see a justification for treating the actual syndrome of delirium. No, I did not see an explanation of that, but I may have missed, obviously, during my literature review. So happy to hear other thoughts.
And it's interesting, 30 milligrams of haloperidol for the hypoactive group, that there were no differences in adverse events, average of 9 to 13 milligrams a day. Go ahead, Michael. There's some comments in the chat box. Go ahead, Michael. You're still on mute.
The use of antipsychotics and hypoactive delirium certainly happens, and it happens in Toronto in teaching hospitals, because when I was ill, I had a hypoactive delirium, and I just found out yesterday through a review of my records that I was given olanzapine, but I survived anyway.
So comments in the chat box. Marjorie Hammond writes, agree it is important for nurses to know why they can use it and under what conditions. Dr. Barb Lou says there are some studies that have tried haloperidol for prevention of delirium in ortho patients. I think that was the Callisvart study. Christina mentions antipsychotic drugs function by blocking D2 dopamine receptors. So the hyperactive theory might make theoretical sense, but hypoactive doesn't really make sense. Further to Gary's statement, Barb mentions prophylactically started prior to elective surgery. And Carolyn, if you'd like to unmute, rather than me summarize your comment.
Sure, it was more of a reflection than a question, but just interesting. You mentioned that Haldol can be helpful for delirium symptoms, but there was no difference between groups in terms of the use of rescue medications. I'm just trying to rationalize that in my head.
And lastly, Christina, thank you. Also, physical restraint use was so low in this study, 1%, that is not typically observed in our ICU patient population. So the generalizability piece. So we're just at the top of the hour. I'd like to thank, unless anybody has any further questions or comments, again, I'd like to thank our two co-chief residents for their presentations, the first one of the calendar year. Thank you both, Guillaume and Amanda. We see some applause in the chat and some whispering. Both beautiful presentations. As a reminder, please complete your evaluations. The link should have been sent, and we look forward to seeing everyone for grand rounds as Guillaume advertised next Thursday, February the 2nd. And lastly, a final special appreciation and thank you to all of our community geriatricians who joined us this morning and prior journal clubs. Have a great weekend.